This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1214, recorded on May 1st, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
I see a black tie with some white specks.
You know, it's the quality of the recording on YouTube will be better than the quality you're seeing there, Vincent.
Okay.
But it's scabies. I'm wearing scabies, ectoparasites today. I'm very excited.
Okay.
But we got a lot to cover. Right when I logged in there, I noticed you were sighing a little. I think maybe you've been paying attention to the world falling apart around us. So I will start with a George Orwell quotation as we enter this Orwellian present. The most effective way to destroy people is to deny and obliterate their own understanding of their history. And so I've added a new section, the attack on science section, Vincent. And I'm going to try to keep speaking about this until it stops. So we might have some time ahead of us. But I want to try to put, a human face on what's going on here. But this week, I'm going to put an animal face on it. So just give people some background. So from an anonymous source, I had previously heard that some of the policies restricting communication at our government agencies applied to ordering supplies, right? So this is the whole idea. Like if you ordered paper or staples, you're communicating with someone outside the agency, that's prohibited. Well, one of those supplies was food for the animals. And a number of these facilities, we had have non-human primates, other animals without food, and actually took legal action to force the government to allow food to be ordered for these animals. So, just craziness, right? So I'm gonna read from what I think is a really compelling article by Emily Anthes at the New York Times. And so here we go. On April 1st, the Trump administration's efforts to slash government funding arrived in Morgantown, West Virginia, where federal scientists spent their days studying health and safety threats to American workers. That morning, hundreds of employees at the National Institute for Occupational Safety and Health were notified that they were being terminated and would lose access to the building. Left behind were more than 900 lab animals. The Institute ultimately managed to relocate about two-thirds of them, primarily the mice, as well as a handful of rats, sending them to university labs. The remaining 300 animals were euthanized. And I just want to point out, this was just the case at the National Institute for Occupational Safety and Health. But this is being repeated across the country. I'll read some more. Many scientists were reluctant to speak openly about what might become of the lab animals, fearing backlash from animal rights activists, retaliation from their employers or the Trump administration. We are facing the prospect of euthanizing millions of animals if there is no course correction. We hear in this article from Dr. Locke, an expert in laboratory animal law and the use of non-animal alternatives in research at the Johns Hopkins Bloomberg School of Public Health. I don't think it's okay to cull millions of animals from research, Dr. Locke said. I don't think that's societally acceptable. I don't think it's scientifically acceptable. And I think we need to recognize that this is a likely outcome.
Malignant incompetence. So, I don't even think they know what they're doing. They're just cutting the budget.
I wish it was just incompetence, but this seems to be an organized attack on science, on a lot of these institutions. I mean, this is the Project 2025 plan, and they're following it. And there's a lot of them. We've already talked about tens of thousands of people out of work. We've talked about now, probably 1 million animals. And a lot of these animals are, really precious, expensive research animals that are helping us try to understand how to treat cancer, how to treat dementia, how to treat, a number of different things out there. So,
yeah, Daniel, the scientific establishment in the U.S. saves lives. how can you want to destroy something that does that? It makes no sense other than being incompetence.
Yeah, I mean, it saves lives. It's an economic force multiplier, right? It's like for every dollar we spend on research, we get $5 back in our economy. I mean, what is going on here? This is short-sighted. This is misguided. This is incompetent. But we still have some science still coming out. So this is a continuing on a story that I think got people pretty excited and still is getting people excited about. So the link between zoster, shingles, and the shingles vaccine and dementia. We talked about a robust study out of the UK. And now this week we've got this article, Herpes zoster vaccination and dementia occurrence, published in JAMA. Very similar design to our last study. Here, this study in Australia, starting November 1st, 2016, live attenuated herpes zoster vaccination was provided free to individuals aged 70 to 79 through primary care clinicians. Thus, individuals whose 80th birthday was just a few weeks before it never became eligible. Very similar, right? And so we've got these sort of two sides. The key strength of this experiment is one would not expect that these comparison groups who differ in age only minutely, really matter of days, would on average differ in any health characteristics, other behaviors. So we've got a sample here of over 100,000 patients. So it's 101,219 patients. About half of them were women. The mean age, 62.6 years. Individuals born just before versus just after the date of this threshold were well balanced in other ways when they look through. And what did they see? There was an abrupt increase of 16.4 percentage points in the probability of ever receiving the herpes zoster vaccination between patients born shortly before versus shortly after. So not as good uptake as we saw before, right? The eligibility rules of the vaccine create this group. The study found that eligibility for the vaccination decreased the probability of receiving a new dementia diagnosis during 7.4 years by 1.8 percentage points. And we have nice confidence intervals there. And really, they show this nice, like over time, cumulative incidence. In eligible people, you're seeing more and more diagnoses of dementia. The eligible people, you're seeing really separation out pretty quickly.
It's a little lower decrease than the other study, I think.
We didn't see huge uptake, I think, in this study. I mean, only 16% people actually went ahead and got it. So,
well, I got my 2 Shingrix shots a couple of years ago, so I'm good. I hope so.
Well, that's the for discussion part I've got here, because people are asking like, oh, this is another one of those studies with the replication competent, old style, attenuated. What about the recombinant shingles vaccine? Well, I just wanted to point out that there was a study back in the summer. I don't know, it didn't get quite as much press, but the recombinant shingles vaccine is associated with lower risk of dementia, published in Nature Medicine. Actually, what this is showing that the improved vaccine is even better than the old attenuated, with about an additional 17% decrease in dementia. So I'll leave that in there because people were all kind of worried, like, should I go? Should I try to find that old shot?
No.
I
think it didn't get publicity because we didn't do it on TWiV.
Is that that's what it is?
Yeah, and also, it makes sense because in the paper we covered on TWiV, they noted that prevention of zoster seemed to be one of the mechanisms of prevention of dementia. So it makes sense that this vaccine would do it because this prevents zoster also.
Yeah, I mean, it's a better vaccine, so we would expect it to be better as far as decreasing dementia, and it looks like it was. So good stuff. Now, the interesting thing I noticed about this article is so all the data, this is the summer one that came out, all the data was U.S. data, but all the investigators were from the U.K. So yeah, it's interesting. Good news, Ebola. Uganda declares end to latest Ebola outbreak. This is going to be about a week from when, this drops. So it's going to be last Saturday, end of April. Uganda declared an end to the country's latest outbreak of Ebola, 3 months after authorities confirmed cases of this hemorrhagic infection in the capital, Kampala. And you do like 2 times 21, so 42 days without a new case since the last confirmed patient was discharged. So good stuff there. And what about bird flu? What's going on with bird flu? So Enhancing the Response to Avian Influenza in the U.S. and globally was published in The Lancet Regional Health Americas. They start with a nice summary. Over 995 dairy cow herds and at least 70 humans have been affected, including cases of severe disease and the first reported H5N1 related death in the U.S. Sporadic human infections with no known contact with infected animals highlight the possibility of viral adaptation for efficient human-to-human transmission. Maybe. They have a whole bunch of bullet points here, sort of recommendations, continuously monitoring animals, testing milk, wastewater, tracking virus evolution, sharing genomic data, using personal protective equipment, self-diagnostic tests, because we know a lot of farm workers are not too excited to go somewhere where they might have that information impact them, funding responses, but bunch of things here. And there's a nice recent cdc.gov/bird flu situation summary where you can see really the hot spots, right? It's out there in California and Washington. So interesting. And a little bit of activity in some other places like Colorado and a few neighboring states. So this is great, right? Because, we're going to have this science group and they're going to meet pretty soon, end of June, and they're going to work on, preventing human bird flu infections. But wait, hot off the press, US CDC cancels science group workshop on preventing human bird flu infections. So the National Academy of Science canceled a work group on preventing human bird flu infections after being told to stop work on the event by the CDC. The National Academies of Science, Engineering, and Medicine workshop was scheduled for the end of June to discuss best practices. They were told to terminate all work on this activity. You don't want to do that.
That's why I think this previous article, how to get ready, we're never going to do any of that anymore. I have zero confidence. So, folks, you better initiate activities to get this administration out of here, or at least put Congress on the right side, because this is going to get worse and worse. And I know that I'm preaching to the converted, but tell your friends that this is really bad. Nice TWiV mug with a red handle.
You like that?
I never saw one with a red handle. Is that from Cafe Press?
And it's even got like the red on the inside
Yeah,
as I
that's
try
very
not to
nice.
spill coffee all over the place. No, we've, see, look at my red handle and the red, we got some red listeners. We're a bike. We try to cross the aisle. What did Obama say? There's no red states and blue states. There's only states of America. So.
Yeah, well.
All right. So measles, the MMWR measles update, United States, January 1st through April 17, 2024, published last Thursday, April 24th. For our listeners, this is a bit of a recap, but we read that a multi-state measles outbreak, predominantly affecting members of close-knit communities with low measles vaccination coverage in New Mexico, Oklahoma, and Texas, began in January 2025. As of April 17, total of 800 cases, 82% of the cases in this New Mexico, Oklahoma, and Texas associated with the ongoing outbreak. It's sort of going to kind of the big thing, a couple sort of hot points here. Overall, 96% of the patients are unvaccinated or we don't know. And there's a message in this report. It's very clearly stated. To prepare for and prevent measles cases and outbreaks, public health departments should continue working with trusted community messengers on culturally competent community engagement, education, vaccination efforts, and other community infection prevention approaches, e.g. case isolation, contact monitoring, and post-exposure prophylaxis, and coordinating with healthcare facilities and schools. Ready for this? Increasing national and local MMR vaccination coverage is essential to preventing measles cases and outbreaks. And that's coming from our CDC. And they've got a nice map where you can really see what's going on. But I was just talking. So my wife's sister, my sister-in-law, lives over in Switzerland. So measles came up, and I wanted to share this headline: Measles cases in Europe, the Americans skyrocket. So measles cases across Europe were up tenfold in 2024 compared to 2023. So far in the Americas, 11-fold higher. We had over 100,000 cases of measles in Europe in 2024. And I'm going to leave in a link here to a couple sources here. One is CIDRAP, one is also ecdc.europa.eu. We can actually see. I mean, we're getting pretty upset here in the U.S. as we approach 1,000. But if you look at Europe, over 100,000 cases last year, and you can look and see some of these hotspot areas are Ireland, right? Austria. Not doing so great in France, where I just was, doing a bit worse in Italy. Yeah.
What's that country? Switzerland. Is that right? No. Switzerland is...
Switzerland, no data. You don't get no
data.
data from the Swiss.
What's the one to the right of Switzerland?
That's Austria, yeah.
And what about the one all the way to the right of Austria?
What is that one? Just bordering there.
It's north of Greece.
Yeah.
I don't know what that is.
I know we got to be better with our Eastern Europe geography there, Vincent. So one of our maybe someone will comment when they're looking at this on YouTube. Let us know what those other spots are.
I'm going to look it up while you go on to your next.
Okay. While you're looking it up, Vincent, I will just update people on. Okay, so the most up to date here in the U.S., we are up to almost 900 as of April 24th. Total of 884 confirmed, right? So more than that, but this is the number confirmed. Measles cases reported by 30 jurisdictions, right? So it's the majority of our country are having confirmed measles cases. Down there in Texas, where the bulk of this is, as of the most recent update, 663. That's an extra 17 just that last week.
That country is Bulgaria, by the way.
Bulgaria.
No, sorry, not Bulgaria. Romania.
Romania, okay.
Yeah, Romania has some health problems.
All right, a disturbing headline in CIDRAP out of University of Minnesota. On the precipice of disaster, measles may be endemic in 25 years if vaccine uptake stays low, model predicts. Basically, let's talk about this article. We're talking about an article here where it's really just a question at our current rate, when does measles become endemic again? I mean, we got rid of measles. It was great. Didn't last very long. And now is really kind of the question with our current trajectory, based upon what's happening, when is this going to happen? So we've got the article, Modeling Reemergence of Vaccine-Eliminated Infectious Diseases Under Declining Vaccination in the U.S., published in JAMA, right? So not just measles, but they're going to look at a bunch of different vaccine-eliminated diseases. So a simulation model is used to assess the importation and dynamic spread of these vaccine-preventable infectious diseases across 50 U.S. states and the District of Columbia. The model evaluated scenarios with different vaccination rates over a 25-year period, and they're looking, sort of as a input, current childhood vaccination rates based upon really the last 20 years of data. Some bad news here, some good news. The bad news is that at current state-level vaccination rates, the simulation model predicts measles may reestablish endemicity, and we have 83% of the simulations saying that might take up to 20 years before it's full-blown, but we're talking about an estimated almost 1 million cases over this period of time. But if things go in the other direction, so if we continue to see this decline, a scenario with a 10% decline in the MMR vaccination, right? Because some people are saying some bad stuff about that. That's not true. Under that model, then we're going to have over 11 million cases over 25 years. The good news, is there any good news here? Other vaccine preventable illnesses are unlikely to reestablish endemicity under current vaccination levels. So we can hold the front there. But more bad news if childhood vaccinations are undermined, as some are trying to do. This is the scenario we're seeing where the dog catches the car. I like that kind of model. If routine childhood vaccination declined by 50%, the model predicts 51 million cases of measles over a 25-year period, almost 10 million cases of rubella, over 4 million cases of polio, couple hundred cases of diphtheria, and then it just goes on, sort of doom and gloom. And they've got these sort of concerning figures where you can look at measles, for instance, polio, and you really see it doesn't take much decrease in vaccination coverage, and then boom, you sort of fall off this cliff.
Unfortunately, this is many years in the future.
Fortunately or unfortunately, I mean, it's unfortunate that it will take a period of time before people realize the mistake they made. There isn't sort of that instantaneous feedback. Yeah. Fortunate is that it's going to be a while before this hits, before we, my daughter Daisy was asking today, she's going to hopefully start working at a children's hospital, and wondering if that's such a wise choice. And yeah, this is, we make the mistake now, and then we see this get out of control.
So that number for polio is huge.
Yeah.
4 million cases of polio. That's more than we had in the heyday of polio. I guess it's partially population increase, right?
I think that's the big issue is population. And it is, just to talk about polio a little. So right now I've actually got 2 patients in the hospital with post-polio syndrome. And I don't know how many doctors see these patients, or if it's just, where I practice and my specialty. And I don't know if I shared these stories. I'll just share them in brief. One gentleman who is in the hospital, he actually got polio when he was about 6 or 7 years old, a young kid. He was in Brooklyn, ended up in the hospital. His friend was in an iron lung. And actually, he tells me the story about how he went to go see his best friend. He spends a year in the hospital, goes to see his best friend, and he calls the nuns were the nurses. And he calls the nun over and says, my friend, his hand is just so cold. Can you warm him up? And it was because his friend had died in the iron lung. This gentleman actually went ahead to serve, are you ready for this? In the Navy, right? Tried to join the Army, and they're like, you had polio, you're out of here. But he really wants to serve because his dad served, won a whole bunch of medals. This gentleman ended up getting into the Navy. They let him in the Navy, and he moves up through the ranks. And he comes from a family of bakers. And so the story is he ends up, as he gets moving forward, he becomes the baker on one of these huge ships, on a battleship. And the bread is so good that they make like thousands of loaves a day, and they're selling them to the other ships. So sort of a entertaining story. But then, and this is a great guy, but now, he's bedridden because he has post-polio. He can't walk. He needs help. And the other gentleman actually had polio when he was 18. He was living in Jersey and got polio when he was 18. And he now, over time, got to the point, wheelchair. Now he's in bed. He's got a trach where he's got the ventilator going in through the front of the throat. So he's chronically on a ventilator. He's bedridden and all the complications that come with that. So, there still are some people out there from those dark days. And, if we're not careful, we're going to let that come back. I mean, this is very upsetting. All right, flu. Moving on to the flu, some good news. We could go back and forth here. Really going in the right direction there. Almost the entire country is green as far as low levels. There's just a little bit, sort of low, moderate in, I don't know, what is that state up in the Northeast?
That's called New York. So we are, Daniel, right now.
Okay, where both of us are at the moment. And the ER visits are really coming down. So things are getting better with flu. But pediatric deaths, this was actually the last update I've got here is April 25th. And flu-related deaths in children climbed to over 200, up to 204. So another 6 children died last week from influenza. This is just a little less than the 207 that we have confirmed last year. So I just want to point this out. This is these are children. About half of them are previously healthy. Otherwise, everyone thought it was fine. 90% the cases they didn't get that flu shot, and now we have over 200 children that did not survive. Moving into RSV, also some good news here. I think we've really gotten out of this RSV season. And, it was a sort of a narrower peak to the season before, a little less RSV than before. So, but really that was quite the flu season we just got through. And COVID, we're getting down to lower levels and our multicolored wastewater. It looks really good. Ignore the South. I don't know what's going on there. That's a blip. It's gonna go away.
A blip. It's gonna go away. There are lots of little blips along the way, as you can see.
Yeah, there always are. You see a little bit of a wiggle here.
It's no worries.
Yeah, but in general, the wastewater levels are getting down to low. So I think that's really great. Now I'm going to talk a little bit today about COVID active vaccination, but sort of as a warning. Next week, we're going to talk a lot more about this because unfortunately, there's a bunch of stuff going on here, which is beyond troubling. So Novavax, let's start with Novavax. What is going on with Novavax? People are either scrambling to find locations with Novavax, driving an hour to the nearest location, or now when this drops after April 30th, they might just not be able to find any Novavax. Now, the FDA had given the company a decision date of April 1st based on this Prescription Drug User Free Act. But people familiar with the situation, the FDA is now asking Novavax, has been confirmed, to conduct an additional randomized clinical trial, which would be prohibitively expensive in order for them to actually go ahead and get approval. I'm not sure how well this sits, because remember, this is the more traditional protein-based COVID-19 vaccine. It's an alternative for people that did not want to get an mRNA COVID vaccine. And we are hearing that this is due to political interference in the vaccine approval process. HHS Secretary said that the FDA isn't proceeding with full approval because he claimed, without evidence, that single antigen vaccines don't work against respiratory viruses.
Does he know what an antigen is, Daniel?
I don't think so. I don't really think so. I mean, he's probably just repeating something he's heard before. So, yeah, I don't think he understands what an antigen is.
So, the spike of SARS-CoV-2 is an antigen, correct?
It is an antigen, but it actually has multiple antigenic sites, right?
Well, it's an antigen with many epitopes, right?
Yeah, I would say
but it is an antigen. And
so
is the Shingrix glycoprotein. It's a single antigen, and it works very well. So this is an outright piece of misinformation.
Yeah. Yep.
It's probably not the real reason why. Maybe what you're going to talk about next is maybe the real reason why.
Well, I mean, it gets worse because, we hear that U.S. health officials have injected new uncertainty into the approval process, not just for Novavax, but apparently this looks like it's deepening to include Pfizer and Moderna shots. So how do we pronounce that? Makari or Makari?
Makari.
Makari. And a spokesman for the Department of Health and Human Services appear to raise the specter that going forward, manufacturers of COVID vaccines might have to generate new effectiveness data before the release of annual updates to their vaccines. And actually, we'll talk a little bit in detail, basically saying before we allow you to update your vaccines, we want to see a placebo-controlled trial.
Daniel, is that done for the updated influenza vaccines?
So their comment was, and we'll talk more in detail when this is sort of like out in the world, but they say, well, you know what? We've been doing that for 80 years. That's a unique situation. That's different. But they're really kind of going after the COVID vaccines. And they're going after a lot of the vaccines, basically saying, and we'll talk more about this, that the VAERS system was designed to fail, that the adverse vaccine injuries are 100-fold higher than anyone really knows. There's been a conspiracy. Yeah, there's a lot of nonsense going on.
This is nonsense. This is complete nonsense.
Yeah, I mean,
there's no conspiracy.
I mean, when they take away people's vaccines, which is what they're trying to do, and we'll see very soon, right? Because we're supposed to very soon be getting recommendations for vaccines for the coming fall for COVID, and here we are in May. I think very soon it'll be clear to people, and hopefully they'll report this on all the media, that the government is coming for your medicines, they're coming for your vaccines, they're taking away your choice.
It will not be reported on Fox, and that's the problem.
All right.
That's why a large percentage of Republicans do not know there's a measles outbreak, because they don't hear it on Fox. And this is the problem.
That's it is interesting. There was I didn't talk about the survey, but yeah, the majority of registered Republicans, when they were surveyed, were not aware that there had been an increase in the number of measles cases.
And Democrats were.
Yeah, majority of Democrats were, which is, yeah. I mean, they probably shouldn't be asking it that way. They should probably be asking, like, what news source do you listen to? And, and I think, as you pointed out, some of the organizations that call themselves blank news are not actually delivering the news. So, all right, not a lot of changes in COVID early viral phase, but a little bit of an update here in the early inflammatory phase. And it's sort of maybe a little bit of an overlap here, but it's with regard to remdesivir. So I may have mentioned that a number of healthcare systems and hospitals are reevaluating remdesivir use. And to be honest, this is driven by financial factors. And I'm going to sort of ask the question, but is this a hill to die on? Are we violating our oath by getting on board with this? One of the healthcare systems I work at was really interesting. They started off with, boy, which antimicrobial are we spending more money on than anything else? And then after that was this whole discussion about maybe we should be limiting that. And I was like, well, you should start with the science. You shouldn't start with the bean counters, right? But anyway, we have the article, Into the Unknown, Practical Remdesivir Restriction in the Era of Widespread SARS-CoV-2 Seropositivity, recently published in CID. So here we look at the impact of restriction of remdesivir among adult immunocompetent patients implemented across an 8-hospital health system. So they're using this pre-post quasi-experimental design, right? So they're going to compare patients 12 months before the intervention, and then they're going to look at 12 months after they start restricting the remdesivir use. The primary outcome was 14-day all-cause mortality. So I'm going to pause right there and cry foul, right? Why not 2-day or some incredibly short period of time? Give me 30 or 90-day mortality, and then we might have a real study. And are we just trying to justify an intervention that will save us some money? Because, 14 days, okay. Anyway, we read on. 4,774 patients were included, 3,323 pre-intervention, 1,451 post-intervention. And then it's going to get, so now the numbers are starting to get small. So we're going to end up with some wide confidence intervals. Not great when you're trying to compare for a difference, if you're going to be properly powered. Significantly fewer patients in the post-intervention group received remdesivir. So that's 37.7%. Pre-intervention, post-intervention, 4.1%. So they first start off by saying there was no difference in 14-day all-cause mortality between pre- and post-intervention groups, odds ratio of 1.8. Wait a second. Doesn't that look like mortality nearly doubled? But they just didn't have enough numbers to reach statistical significance because of wide confidence intervals? All right, so that's how I'm going to read the first thing. So there was nearly a doubling in 14-day all-cause mortality, but they didn't have enough numbers to reach statistical significance. Now we're going to read on. ICU admission and mechanical ventilation use were also different between groups. Remdesivir use was associated with a lower risk of ICU admission and mechanical ventilation pre-intervention. And let's even look a little bit closer at the data because they got this nice table too. And so maybe David will have this up. People can look at it. This is table 2. And we'll look at outcomes and treatment effects by time period and remdesivir use. So looking through here, I'm seeing a 40% increase in 14-day mortality, but wide confidence intervals. So as mentioned, we don't get the statistical significance. A 4-fold increase in ICU admission, a greater than 9-fold need for mechanical ventilation, that's getting intubated, a 60% increase in length of stay. So are they really saving any money here? Or do we just have more people dying, longer hospital stays, more people in the ICU, more people ending up on ventilators? Is this a rigged analysis to justify making a financially driven change that only saves money if we limit our view to pharmacy costs?
Yeah, this is the kind of thing that Jay Bhattacharya would do just to get the economics going.
Which is really crazy, right? Because, you say you're increasing hospital stay. Like, how much money are they saving on the remdesivir if you start increasing hospital stay? Those beds are, are full. That person, the way it works, you've got more people boarding in the ERs. You've got more people dying. So, all right, just throw that out there because I know that the headline will be the headline. The headline will be that, look, no change in primary endpoint. So. All right. In this section, we've also got the interesting article, Tocilizumab and IVIG experience during the service follow-up in patients with severe COVID-19 pneumonia, published in the Open Access Journal. You ready for this? The Revista do Instituto de Medicina Tropical de Sao Paulo. So in this study, they looked at the effects of early administration of tocilizumab and IVIG on clinical outcomes in patients with severe COVID-19. Patients with progressive clinical and laboratory deterioration who received tocilizumab or IVIG between July 2020 and October 2020 in a public hospital ward were retrospectively evaluated. Not a lot of numbers here. A total of 74 patients identified. 29 get IVIG, 26 get tocilizumab. They found that patients with severe COVID-19 who received IVIG in an early stage of the disease did not have better clinical outcomes regarding mortality, length of stay, and ICU admission compared to those who received tocilizumab. If anything, they observed concerning side effects with IVIG, such as bradycardia.
So this is being given to hospitalized patients. So they're past the viral phase, right?
Yeah, so this is trying to target that inflammatory stage. Really not the time for IVIG.
No.
All right, long COVID late phase. We've got the article, Risk of New Onset Type 2 Diabetes Among Vaccinated Adults After Omicron or Delta Variant SARS-CoV-2 Infection, published in JAMA Network Open. So we've talked before about how, someone's never been infected before. They go on, they get a SARS-CoV-2 infection, and we see increased, diagnosis of diabetes after that. So earlier pre-Omicron studies reported increased, like somewhere 25, 27 to 46% increased diabetes risk after SARS-CoV-2 infection. We even saw increased risk following Omicron infection in Hong Kong adults. So it really looks like infections in naive patients are really bumping up this risk of ending up with diabetes. But what about vaccination and boosters? So what if you got vaccinated? What if you're keeping up with those boosters, which up until now they've allowed us to do? So this cohort study used Singapore's National COVID-19 Registry to construct cohorts with a positive or negative SARS-CoV-2 test. They're looking September 2021 through December 2022. Vaccination status and new onset type 2 diabetes were determined using the National Immunization Registry and the National Diabetes Database. Now, they do a bunch of analyses. In subgroup analyses, increased post-infectious risk of type 2 diabetes was observed during Delta predominance among Indian individuals, but not among Chinese or Malay individuals. During Omicron predominance, elevated post-infectious risk of type 2 diabetes, hazard ratio 1.50, 50%, was observed among unvaccinated or partially vaccinated, but not among fully vaccinated or boosted individuals. Compare with historical influenza hospitalizations, patients with COVID-19 had 45% higher post-acute risk of type 2 diabetes during Delta predominance, 56% higher during Omicron predominance. So the variant didn't seem to make a huge difference. What made a big difference, if you were fully vaccinated, getting your booster shots, we were not seeing excess diabetes.
What do you think about this population difference?
So it's interesting. And, if you go to Singapore, there's really there's different populations in Singapore. So and this has to do just with sort of the phenomenon there. And this is also part of why Singapore is a separate place, because Malaysia had this rule: we don't want more than a certain amount of our population to be Han Chinese. Mm-hmm. And that was part of why Singapore broke off. So there's a large Han Chinese population, a Malay population, an Indian population. But it looks like there's some sort of a genetic background here impacting the risk. All right. I'm going to leave in a link because if you're fired up after listening to this and you want to reach out to your representatives and say, please, I want access to my medicines. I want access to my vaccines. I want, so house.gov/representatives/find-your-representative. You can, let our government know what you want. And I open that to everyone on both sides of the aisle and those that are trying to somehow stand in the middle. And as we've been saying for a while, no one is safe until everyone is safe. I say low and middle income countries. Apparently now I'm referring to the United States of America as well when I say this. We just finished our Floating Doctors fundraiser, and thank you. Thank you to everyone listening who contributed. We reached our goal. We're going to be sending that check. I authorized it to be sent to help out floating doctors. And now May, June, and July, because we're in May, we are going to be doing our Foundation International Medical Relief of Children fundraiser. Again, doubling your donations, hopefully getting up to that maximum donation of $20,000.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Carson writes. Now, Carson was the fellow who wrote last week, and he had COVID, and he's been coughing for many, many weeks afterwards. You remember that,
Yes,
Daniel?
yes, yep.
So he says, update, it's human metapneumovirus.
Okay, one of my favorites, right?
Went to urgent care just to have someone listen to my lungs and make sure that things sounded fine. They also did a respiratory panel and a chest x-ray, normal aside from some mild bronchitis. Still curious about how far out someone might experience COVID rebound. It's not rebound. It's the inflammatory phase. And
Thank you.
What do you think, Dan? How far out can you?
Well, I gotta comment on two things. So one, right? I mean, Carson, remember we encouraged you. You said go see the doctor, and so that worked out. Now you know what was going on. You had human metapneumovirus, which is a very inflammatory infection, and this is the timing, right? We just got through most of our winter respiratory season. RSV comes down. This is when human metapneumovirus comes up. So you got COVID, and then you got human metapneumovirus, and that happens. Now, as far as the post-acute inflammatory phase, I mean, unfortunately, a lot of people go on and they don't get better for months and months. This can go into that long COVID. But fortunately for you, it sounds like it's human metapneumovirus, which just lets everyone know with a little bit more reliability than the groundhog that spring is almost here.
Brittany writes, as a mother of two kids, one of which was born in full 2020, I have been a vocal proponent of COVID vaccines. This story is alarming, and she says a link to the story about the FDA vaccine approval process for COVID vaccines, which Daniel has already just talked about.
Yeah.
Those of us who have stayed informed of the COVID vaccine process know that this ask from the FDA is virtually impossible. What can us laymen do to put pressure on the FDA to stop this nonsense? I've called my senators over and over again, but RFK Jr. continues to get away with this as he dismantles every bit of progress we have made in public health in the past century. That's a good way to put it.
No. And Brittany, I mean, keep doing this. Keep reaching out. I mean, they keep track of the phone calls, the letters, the emails. Just keep letting people know. And this, people wonder, say, oh, I live in a blue state. Does it really matter? It matters. If you live in a red state, it matters. It's, people want to be healthy. People want to have access to their vaccines. They want children to have access. There's a lot of discussion, sort of targeting mandates. We're not talking about mandates here. We're talking about, these players taking away our choice, taking away our access.
Tell your friends too. That's the best way to spread this and get them to know what's going on.
And for the little kids coming into this world, we've really changed things. And I was describing, older gentlemen who are in the hospital really suffering from something that happened to them as children because they did not have this protection, which we've been taking for granted for a while. So have these discussions.
Ellen writes, the scientific, in quotes, argument supporting vaccine hesitancy is following. Vaccines affect the immune system. Agreed. Effects other than those desired and measured are not known. It is possible that such effects might compromise the immune system in undetected ways, weakening it against other pathogens or being otherwise deleterious. If you could address this argument, it would be very helpful.
Okay. Yeah. I mean, we've been vaccinating for many, many years now, right? This is not a brand new thing. So we have decades and decades of experience of what happens. People get vaccinated. You're going to hear stuff coming up about, VAERS, it's rigged. They're hiding it. There's a conspiracy. None of that's true, right? We live in this society. We live in a society where most people are getting vaccinated. What do they say? What's the biggest side effect of a vaccine? Adults, right? You make it through childhood, you're healthy, and you end up as a healthy adult living into your 70s or 80s, right? Go to the parts of the world where they have trouble getting access to vaccines. And the life expectancy is not late 70s. So no, there is this argument. It's out there. We do measure, we do pay attention to everything that happens. There's a lot of post-marketing surveillance. So I think this is just an invented argument, really just to justify a position, not really people that are truly interested in the truth.
Aaron writes, I have a 6-month-old son who is getting all his recommended childhood vaccines on a typical schedule. I'm concerned about the growing number of measles cases in the U.S., and I'm curious about giving my son an MMR dose now before he starts daycare next month. This would be in addition to the standard 2-dose regimen beginning at 12 months. I've read mixed reviews about the effect an extra dose before 12 months has on the efficacy of the later standard 2-dose regimen. Is there any high-quality data suggesting that an early dose at less than 12 months of age really makes the later standard 2-dose regimen less effective at preventing measles? I am not in an outbreak area, nor am I planning international travel. I'm in California, so there are cases in my state, including one in a neighboring county, but no outbreak in my area yet.
All right, writing from Truckee, California. So, Aaron, we shared a study a few episodes back where if individuals, the timing at 12 months seems to give this really robust, long-lasting immune response. It looked like if you got a dose before 8.5 months, that there actually seemed to maybe be some tolerance, some kind of an early waning, maybe a negative impact. Sarah Dong and I recently shared another paper on the ID PUScast that dropped yesterday, looking at like an at birth dose. Yeah, we're not sure, but there is some concern getting it before 8.5 months may actually impact. So there's some concerns, and that's why when people talk about messing around with the vaccine schedule and a little bit here, a little bit there, this is the schedule that was studied. So a little bit of a challenge here, I see. So 6 months of age, 2.5 months before you get to that 8.5, if you're able to wait a little bit longer, but yeah, you don't want to have this tragedy, particularly as what we're facing in some of these areas with our outbreaks, where, you get the infection without the protection.
And a comment from Lisa, she sends an article. The Florida House passes a bill barring healthcare discrimination based on vaccine status. And she writes, here in Florida, in addition to working to outlaw fluoride in our drinking water, there's this. Because Florida, it's where old people and science both go to die.
I like that. Oh, my gosh.
As a pediatric nurse practitioner, I'm angry and horrified and am in the midst of writing letters to my politicians as well as to my effing idiot of a state surgeon general. Years in, and I still listen weekly to clinical updates. Thank you, and Vincent, for continuing to speak up.
Thank you, Lisa. And I love your quotation, Florida, where old people and science go to die. I'm going to make a bumper sticker.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Thank you. And everyone, be safe.